We are getting started with the session, everyone. Good evening, one and all present here. I am Mona Lisa from ClearNet, a designated session assistant to ensure a seamless experience. ClearNet proudly stands as India's premier digital platform tailored for doctors, providing a wide array of invaluable services. ClearNet is elated to be chosen as the digital partner for this event organized by Association of Aesthetic and Regenerative Gynecology India welcomes you to the webinar on Masterclass on Non-Surgical Management of SUI. So thank you for your patient listening, everyone. Let us get started with today's session, for which I would like to play the Ganesh Vardhana first.
प्रणम्य शिरसा देवम् गौरीपुत्रं विनायकम् भक्तावासं स्मरे आयुः कामार्थसिद्धये.
Thank you for your patient listening, everyone. Let us get started with today's session, for which I would like to call upon Dr. Prerna ma'am to take the session forward. Over to you, ma'am.
Thank you, Mona Lisa. And we are here again with a very, very interesting session of the Association of Aesthetic and Regenerative Gynecology Society of India, INSARG. There's a master class on non-surgical management of SUI. We have been coming through for the last 3 months now with various episodes and from faculty all across the globe. And the brainchild of Dr. Naren Malhotra sir and Dr. Ragini ma'am. This has come a long way now that we are taking INSARG to every nook and corner of the country as well as abroad. I welcome our patron, Dr. Naren Malhotra sir, and our president, Dr. Ragini Agarwal madam. Dr. Ragini ma'am, for your presidential address. Ma'am.
Thank you, Prerna. Very good evening to one and all. Welcome to this master class. This class is basically masterminded by Malhotra sir, that we should do something different than only the lectures by the international national faculty, that we will come once in a month. And now this has changed. We will take one topic and dissect it out completely. You all are agree that SUI is something which is very common, and it has come as a pelvic dysfunction. Today, when the difficult surgeries and specifically the mesh is going out of many countries, even banned it, what we are going to offer our patient, it is a question, very big question. So only one thing cannot do everything. If you think that only EBD is going to do the wonder, no. Only FeMiChair is going to do wonder, no. There's something beyond. We have to talk about the woman from one side to other side. We have to strengthen the pelvic floor. So keeping this mind, we have made this program where we are only going to talk about the non-surgical management of the SUI, from how it has started, how we can prevent it, what's the pelvic physiotherapy, and what the non-surgical modalities we have here. So let's start with the program. I invite Dr. Malhotra sir for his blessings.
Very good evening to all of you. It's indeed a pleasure to be again joining you on the second and the fourth Wednesday with INSARG. INSARG, as you know, is the Indian Society for Aesthetic and Regenerative Gynecology, formed the only national society which is recognized by the European and the World Associations. And we are into holding webinars, annual conferences, and training courses all over India. And our endeavor is to this new specialty, which is mushrooming so fast that every corner there is a training course going or something going on, has to be regularized before the government puts a clamp on us. So that is exactly why the Indian Society has been formed. as a national. And I urge all of you who are listening here, even from Nepal, which I believe, to join the INSARG and take advantage of our educational meetings. Today, as Dr. Ragni said, there is a presidential series where we get an international speaker and a national speaker, and one Wednesday will be a master class on one subject. So we've chosen SUI, and we thank Akar for supporting this. And we will try to tell you all about what is urinary incontinence, how many women suffer. It's her unspoken problem. 7 out of 10 women will, if you ask them, would have had a urinary leak sometime or the other. And surgery, everyone is scared. Medicines have their own side effect and don't work. So Kegel exercise is not done properly, will not work. So a lot of things. And then we have, of course, the energy-based devices like the lasers, the RF, the high fem chairs. And today we're going to demonstrate and show you about the high fem chair also. So congratulations, Dr. Ragni, for starting this master classes. And welcome all the delegates. And I hope you all enjoy this academic feast and have a lot of questions to us so that we can sort out all the problems. Thank you once again for giving me this opportunity to chair this session.
Thank you, sir. Thank you for your words of wisdom. And indeed, as Dr. Ragini and Dr. Nalit Malhotra sir has said, that every household problem SUI is. Every now and then a female leaks, and that is her unspoken problem. Very rightly said, sir. And sir, under your apt guidance and nurturing aptitude, we will take our endeavors through and through to the entire globe so that these women doesn't suffer in silence. And Ragini ma'am, a very meticulously tailored program that we have today. We welcome everyone on board. And with this, we start our very first session. To chair the very first session, we have Dr. Nalin Malhotra sir, patron INSARG, and Dr. Milind Shah sir, who is the Deputy Secretary General of INSARG. Can we have the CVs of our experts, please? Mona Lisa. Can we have Dr. Nalim Malhotra CVs, please? Sir is the managing director of Rainbow Healthcare, and we cannot really introduce Sir in one single minute because Sir has so many credentials. He's a director of ART Rainbow IVF, he's a director of Foxy Manyata CSC, he's a director of Project Positive Health Rotary District 3110. He is a name and he is a role model and an icon for all the youth Foxians and across the country gynecologists. Sir is a professor of School of Science and Technology, Croatia, has been the past president of ISAR, ISPAT, and all the very prestigious organizations that we can name in the list. He's the founder, editor of Suffolk General, member of FIGO Guidelines Committee 2014-17, chairman of Smriti NGO, and Sir has immense number of papers and publications to his credit. And Sir is a role model and a path and a guiding icon for all of us who have joined in today. Thank you, Sir, for being here, and thank you, sir, for being a part of this particular organization. You have taken this organization from a very nursery point to what it is today, the Association of Regenerative and Aesthetic Gynecology. We are very much blessed to have you amongst us, sir. We have a second expert, Dr. Milind Shah, sir, who is the Deputy Secretary General of INSARG. Can we have Milind Shah, sir's CV? Sir was a president of ISOPAB in 2016-18, and right away he is the Deputy Secretary General of our organization. He is the member of Maternal Fetal Medicine Committee of AOFOG, and a very wonderful friend, a philosopher, and a guide in every sense of the term. Sir has been the president of IMA Solapur branch 21-22, a very active Foxian, and a founder president of IHRF Infertility and High Risk Foundation. Has many publications and awards to his credit. We welcome you, sir, for being with us to chair this very pertinent session of etiopathogenesis and types and diagnosis of SUI, which Dr. Karishma Thariani will be taking up. Can we have Dr. Karishma Thariani CV, please? Dr. Karishma is the president designation consultant, present designation of having Center for Urogynecology and Pelvic Health as a consultant. And her major areas of interest is definitely urogynecology, which she is going to speak about today, pelvic reconstructive surgeries. And she has been a member of Educations Committee IUGA, member of Prolapse Committee IUGA, reviewer of International Urogynecology Journal Indian Pediatrics, and faculty at various national, state, and international conferences. Consultant at previous affiliation, Bharatiya Institute of Science and Research Assistant Professor, Lady Hardinge Medical College. We are very overwhelmed to welcome you, ma'am, for this very important topic of etiopathogenesis, types and diagnosis of stress urinary incontinence. The dais is all yours, ma'am. Dr. Karishma.
Thank you so much. I would like to share my screen. It says you cannot share the screen while other participants are sharing. First of all, I would like to wish a very good evening to all the respected chairpersons, seniors, and my dear friends. First and foremost, I would like to thank INSARG and Dr. Ragini for this opportunity to be present here in this esteemed dais and to be able to say a few words. The topic that I shall be talking about is stress urinary incontinence, etiopathogenesis, risk factors, and diagnosis. Are my slides visible to everyone?
Yes, ma'am.
Yeah. So first of all, as we all know, urinary incontinence refers to any complaint of involuntary loss of urine. It may be a sign, it may be a symptom, or a diagnosis. The three most common types of incontinence are stress urinary incontinence, urgency urinary incontinence, and the mixed urinary incontinence. Today, we shall be talking about stress urinary incontinence. We know stress urinary incontinence is the complaint of involuntary leakage of urine whenever there is an increase in the intra-abdominal pressure. It may be with exertion, sneezing, coughing, laughing, heavy weight, etc. Yes, as Dr. Narendra Malhotra just said, it is a huge problem. It is not a life-threatening problem, but yes, the problem burden it's so excessive because this problem affects a woman's social, mental, physical, sexual well-being. It makes a woman lose her self-esteem. Like Sir said, the incidence is 7 out of 10 women. And if you look at the studies, the incidence varies from 5% to 70%, increasing with age, being almost 45% being between the age of 61 to 70. Out of all types of incontinence, stress urinary incontinence is the most common type. Annual incidence in our country is 20% of women who are diagnosed. There are many who do not report their symptoms. There are many who still consider stress urinary incontinence to be a normal part of aging. Risk factors, like I said, it may be associated with childbirth, genetic predisposition, strenuous activity. These days, a lot of younger women indulge in a lot of fitness activities like running in marathons, lifting heavy weight. I'm not trying to say that this is bad. It's excellent. Strength training is great. But while you're strength training, lifting heavy weight, you also need to exercise your pelvic floor, to strengthen your pelvic floor. Otherwise, now a lot of younger women are coming to us with stress urinary incontinence. Menopause is a risk factor. As you age and as we move forward in this presentation, we will see how menopause affects the continence in a woman. Increasing age, obesity. Obesity plays a multifactorial role. Besides the increasing weight, putting increasing pressure on the pelvic floor, obesity also leads to increase in the visceral fat in the abdomen, which raises the intra-abdominal pressure. That is why obesity is another problem that our country is currently dealing with, leading to an increase in stress urinary incontinence. Before we go into the details of SUI, let us understand how is the continence maintained in our body so that how SUI happens becomes easier. We know the lower urinary tract consists of bladder and urethra, and the main function of these two organs is storage of urine and voiding of urine. This is known as a micturition cycle. An ideal micturition cycle would be when the bladder is able to accommodate increasing volumes of urine without an increase in pressure. It is an outlet which remains closed while I am at rest. I am talking to you. The outlet of the bladder should remain closed. And there should not be any involuntary bladder contractions. I should not keep feeling the urge to go while I'm talking to someone or taking a lecture. Ideal bladder emptying phase would be a coordinated contraction of the bladder smooth muscle, the urine coming out easily out of the outlet without any resistance, This would be an ideal micturition cycle. Now, what leads to this ideal micturition cycle? It is not just the bladder and the urethra. It is because of the concomitant action of the pelvic connective tissue, levator ani, bladder, urethra, and the neurological pathways. How does the urinary bladder helps in maintaining continence? See, one of the biggest rules in a woman not leaking is the bladder pressure being less than the urethral pressure. This is the main rule. Now, let us see how the anatomy of the bladder helps in this thing happening. We know that the bladder is a hollow muscular organ. It is lined by urothelium, which is nothing but the transitional epithelium. Transitional epithelium has an innate capacity to stretch with increasing volumes. The second layer is the lamina propria. Now, this layer is a layer of loose connective tissue, which gives the bladder a lot of area to expand when it fills up with urine. Third layer is the muscular layer of the bladder, that is the detrusor. Unlike the other viscera in the body, the detrusor in the bladder is not arranged in the typical inner longitudinal, outer circular, and kind of fibers. In the bladder, the detrusor is arranged in a haphazard fashion. This helps in the bladder enlarging uniformly as the urine fills in. Now, every time the bladder fills up with urine, it follows the Laplace law because of the arrangement of the muscle fibers and the collagen elastin tissues in the bladder wall. With increasing volumes of urine, the bladder pressure does not rise and stays at a basic bare minimum, say 10 centimeter of water pressure. This is a very important part in maintaining continence. Second is the urethra. Now, we know urethra is not like a pipe. It is a collapsed structure. And this collapsing of the structure or coaptation of the urethra plays a very important role in maintaining continence. If you look at this cut section of the urethra here, you will see that the lumen is lined by transitional epithelium. This transitional epithelium has glands, which produces secretions. These secretions of the urethra help in keeping the urethra closed by increasing the surface tension inside. This is called coaptation. Second, again, under the epithelium is the lamina propria. Now, this lamina propria has a lot of venous plexuses. These venous plexuses are very sensitive to the estrogen level. That is why, under the influence of the estrogen, these venous plexuses stay congested and keep the urethral lumen closed. That is why when a woman menopauses, these venous plexuses become less congested and the urethral pressure starts to fall. The third layer we know is the muscular layer, consists of the smooth muscles and the striated muscles. The intrinsic urethral sphincter is nothing but the continuation of the detrusor fibers from the bladder. The extrinsic urethral sphincter comprises of three main muscles: the sphincter urethrae, the compressor urethrae, and the uretrovaginal sphincter, along with the skeletal muscle fibers of the pelvic diaphragm. If you look at this picture here, you will see that all of these three muscles are concentrated at the level of the mid-urethra. And that is why when we place the synthetic urethral slings, we place them at the level of the mid-urethra. Third factor which helps in maintaining continence is the position of the urethra. Proximal urethra is kept intra-abdominal because of the tonic contraction of the levator ani and the attachment of the urethra to the pubic bone by the pubourethral ligament. Now, if the levator ani, every time a woman voids, the levator ani relaxes. As the first step, the urethra descends down and the uretrovesical angle is obliterated, leading to urination. This urethral elevation is the physiological basis of Birch-Kolpo suspension. So if we were to revise the supports of urethra, we can divide them as intrinsic supports and extrinsic supports. Intrinsic supports would be the epithelial coaptation, the congestion of the submucosal venous plexuses, the smooth muscles, and the striated muscles, which are thickest in the mid-urethra. The extrinsic support would be levator, endopelvic fascia, and levator and the endopelvic fascia. Now, what is intrinsic sphincter deficiency? This term comes across a lot of times when we are talking about SUI surgery. Intrinsic sphincter deficiency is any urethra which cannot maintain a watertight seal at rest. It may be hypermobile, it may be fixed. This is not a pathophysiological process. It is just a diagnosis for severe stress urinary incontinence. That is a urethra which cannot stay coaptated, not at all, due to which the patient is walking with an open pipe and she leaks, that is, she has severe incontinence even even on movement, even on getting up from sitting posture. That is what intrinsic sphincter deficiency is. Now, what happens during stress? Every time a woman coughs, sneezes, because the proximal urethra is intra-abdominal, the abdominal pressure is transmitted to the proximal urethra. This causes compression of the anterior and the posterior urethral walls, again facilitating coaptation, active compression of the urethra against the pubic bone, and contraction of the striated external urethral sphincter, which is called the guarding reflex. If any of you just coughs or laughs loud, you will feel a small pelvic contraction happening if you focus. This is what the guarding reflex is. So this is what D. Lancey also said in his theory, that the extrinsic supports of the urethra form a hammock under the urethra. Now, as long as this hammock is there, whenever there will be increased intra-abdominal pressure, the urethra will close against this hammock. And the moment this hammock is lost, as in figure B, there will be leakage of urine. If this hammock is maintained, a patient may have the largest cystocele in the world, but if the hammock is maintained, she will not leak. So it is this urethral hammock, periurethral hammock, which helps in maintaining this seal. This was the D. Lancey's theory. Now, from the etiopathogenesis, if we keep this in mind and start evaluating the patient, we will be able to understand how various tests work and how easy it is to diagnose a patient of SUI. The diagnosis of SUI is purely clinical. Very few testing is required and only very few indications for higher tests. So whenever you're evaluating such a patient, you have to look for all the factors which may worsen incontinence, which may influence the patient's choice of treatment and the success of treatment. I always divide my history into presenting complaints, elicited complaints, and treatment planning issues. Presenting complaint is the complaint with which the patient has come. But a woman who's leaking excessively and is very bothered by it will not tell you about the other things which are less bothersome. So we have to ask her so as to address all the pelvic floor issues which may further lead to worsening of the incontinence. So first of all, the patient will come and tell you that she is leaking. She will not tell you whether she has SUI or urge incontinence or mixed incontinence. So first of all, our history should be pertaining the type of incontinence. Are you leaking on sneezing, coughing, movement, or are you leaking on the way to the bathroom, or both, or any other history pertaining to her or is she wetting the bed at night? All these histories are important. Once you've tried, you've asked her about the type of incontinence, then how often does it occur? How much? Aggravating and improving factors. How much is it affecting her quality of life? Is she using a pad, diaper, anything else to stay dry? Ask her about all other storage symptoms like urge, nocturia, bladder sensation, discomfort on holding urine. Then come to the voiding symptoms. Voiding symptoms are extremely important, like hesitancy, slow stream, intermittency, straining to void. Imagine a patient who's straining to void and has stress incontinence. The moment you put in a sling, the sling will never work in her. She will not be able to pass urine with a sling inside because she's straining. Every time she will strain to void, the sling will get tighter and the patient will not be able to pass urine after surgery. So all these complaints tell you what further workup is required. History of constipation, very important. History of fecal incontinence. History of other comorbid conditions. Past history of urinary tract infections. Drug history. Is a patient on diuretics, any drugs with anticholinergic actions, etc. Past surgical history and any other treatment taken for incontinence. Along with this history of other treatment planning issues is also very important when we are addressing issues like incontinence. For example, what are the patient's goals and expectations of treatment? Imagine a 40-year-old lady with moderate incontinence who was a sports teacher in a school. On the other hand, there's another 40-year-old lady who's a housewife and does not engage much into much active lifestyle. Which patient out of these two will you consider for conservative, and which out of these two will you advise a surgery? So patient's goal and expectations are extremely important. Cognitive function of the patient support. Does she have family support before we ask her to come for physiotherapy sessions every week? If an elderly lady is there and you're calling her for 3 sessions a week, does she have enough support? Anyone who will bring her to you? Otherwise, she will never come back. And her desire for treatment of that issue. So these are the things which should also be kept in mind. Coming to examination, like I said, stress incontinence is purely a clinical diagnosis. So examination plays a very important role. Always talk to the patient while you are taking her history, and that gives you an idea about the patient's mental status and cognition level. Obesity, physical dexterity and mobility are also important to judge before we tell her any kind of further treatments. Abdominal examination we know is important to rule out any mass impinging on the bladder, hernias, etc. Pelvic examination. So first, whenever a patient of stress incontinence comes to me, I like to examine her comfortably full bladder. She should not be over full also. Ask the patient to cough, and if she leaks, that is suggestive of stress urinary incontinence. Another thing which is important is the duration between the cough and the leak. If the patient coughs 5-6 times, then feels an urge and the leakage occurs, that is a patient who needs further investigation to rule out cough-associated detrusor overactivity or CADO. So the timing between the cough and the leak is also important. If the patient has concomitant prolapse, if she doesn't leak on full bladder with the prolapse out, deposit the prolapse to look for occult stress urinary incontinence. Once you have seen, you've done the cough stress test, ask the patient to go and void. Ask her to come back and lie down again. Make her cough again. If she leaks on an empty bladder, that means her empty supine stress test is positive. Empty supine stress test positive means the patient has severe stress urinary incontinence. So this is a very simple clinical test in which you can differentiate between a mild, moderate, and severe incontinence just by clinical examination without any urodynamics and other things. Then PSP, we know a speculum examination, bimanual examination is important. Always look for vulvovaginal atrophy so that you can advise patients vaginal estrogens if that is present. Another very important thing is doing the Oxford score of the patient. Because for knowing calling the patient for further sessions of physiotherapy, high FEM, etc., you should know what the patient's baseline pelvic floor muscle score is like. A neurological examination should also be done, which includes very simple anal reflex, bulbocavernous reflex, and perineal sensation. In further workup, urine test should always be done because in elderly women, sometimes just the presence of leakage may be a sign of a UTI. So it's a good idea to do a basic urine analysis in such patients. Always keep a questionnaire handy with you, which will help you in following up the patient. Another very important thing in assessment is the bladder diary. I think it is one of the most, it is the simplest things which is often neglected by most clinicians and patients also because of the timing involved in filling a bladder diary. But a bladder diary gives us a lot of information about the frequency of micturition, amount, bladder capacity, incontinence episodes, type of leakage, and the impact of that leakage on the woman's day-to-day life. This is an AUA bladder diary. It is freely available on internet. I urge all of you to keep printouts in your clinics and always urge your incontinence patients to fill a bladder diary. It can also be used to maintain data to help the patient, to follow up the patient. Because nobody remembers that I used to leak 5 times per day before 3 sessions of physiotherapy or HIFM. Now I'm leaking only twice. So such minor differences can also be picked up by a bladder diary. A post-void residual examination should be done in all women with incontinence who have any voiding issue. If a patient tells you that she has any kind of difficulty in voiding, please do a post-void residual. It can be easily done using an ultrasound machine or a single pass catheterization if you do not have access to an ultrasound machine in your clinics. Any volume less than 50 ml is usually considered as normal. Values more than 200 are abnormal. But if you want to understand the formula, then any value less than 1/3 of the pre-void can be taken as normal. Q-tip testing to look for hypermobility is not recommended anymore by any of the international agencies or even Urological Society of India. So it is now not advocated to be done. It's also an invasive test which can lead to irritation in the urethra. Uroflow is another test which I always urge all my fellow friends and gynacs to do. Is a very basic uroflowmetry. It is inexpensive. It is non-invasive. And don't get intimidated by the values. Always look at the curve, even if you don't remember the values. This is an ideal uroflow. It is a bell-shaped curve. If your patient has a bell-shaped curve, she probably does not have any voiding issues. That is a safe patient to operate upon, to give medications to. Now imagine you have two patients of stress urinary incontinence. One has a uroflow which looks like this, and other has a uroflow which looks like this. Which patient will you be more comfortable operating without a urodynamics? Certainly not this one. In this patient, I will not operate or give any kind of medical treatment till I investigate this patient further, because she has severe voiding issues also along with her incontinence. Imaging of the pelvis and upper urinary tracts is done to evaluate any other existing pathology. Upper tracts should be imaged if your patient has hematuria or raised post-void residual or severe untreated pelvic organ prolapse or any other thing which makes you feel suspicious that she may have the upper tracts being involved. Now, with this evaluation, you will be able to differentiate between a patient of complicated incontinence and uncomplicated incontinence. Any woman who has recurrent incontinence, incontinence associated with pain, hematuria, recurrent infections, significant voiding symptoms, history of radiation, history of pelvic surgery, or suspected fistula is a complicated incontinence. It is best that such patients are referred to a specialist. All other patients can be conveniently treated by all of us. Now, this is a very common question. When to do urodynamics? Is it required in all women with SUI? Is it not required? So my opinion is do a multi-channel urodynamics only when you're suspecting that the patient has mixed urinary incontinence. She has severe voiding dysfunction like the uroflow that I just showed you. If she has concomitant prolapse and you're planning the patient for a concomitant sling and prolapse surgery, if the patient has previous history of failed incontinence procedure or any other situation where you feel that your primary treatments have not worked, those are the patients where a multi-channel urodynamics should be done. If you have a patient who has no significant residual, no prior urinary tract surgery, no prolapse, pure SUI or stress predominant mixed urinary incontinence, you can even operate on such patients without a multi-channel urodynamics, but please always do a uroflowmetry so that you have a basic idea. If you feel that the uroflow is not normal, send the patient for a urodynamics. A cystoscopy is only recommended in very selective cases who have hematuria, pain, if recurrent infections, recurrent urgency, or discomfort. So in the end, I would like to summarize. The most important thing is history. Just ask till you and the patient both are satisfied. Do a complete examination in all patients. Voiding symptoms oftentimes present as storage symptoms. Patient may have voiding difficulty. She can present as urgency, leakage, worsening of stress urinary incontinence. Always ask for voiding symptoms. A thorough workup not only helps in accurate diagnosis, but also helps in optimizing treatment outcomes. Thank you. Thank you for patient listening.
Unmute kar lo, Prerna.
Fantastic presentation. Absolutely very well dealt and clarified. A lot of things, new things went into my head also on when to do what and work. So this is where the gynecologists make a mistake on when we try to evaluate. Whenever a woman comes, we have to just take that history and come to a clinical diagnosis of what it is: SUI, overflow, urge, or a mixed, and then do the investigation and of course then treatment. Most of the time people will just write a treatment blindly and do that. So that's very well done. Thank you very much for that lovely explanation.
Thank you, sir.
Thank you, Dr. Karishma, for that very elaborative talk and really exhaustive explanation of etiopathogenesis. And really, it was a great learning experience from your wonderful deliberation. So we do we have Milinda, sir, as
No, Milinda is
joining in? So Dr. Ragini, you can give your expert inputs here.
Yeah, I will start my presentation and give my inputs there only.
Okay, so we have
Next
our
presentation is mine.
next
Yeah,
speaker, our very beloved and our very own president INSARG, none other than our very dynamic Dr. Ragini Agarwal, ma'am. She'll be giving an overview of non-surgical management of stress urinary incontinence. And can we have ma'am CV,
नहीं
please?
CV नहीं दिखाओ, बस हो गया
Achha.
रहने दो.
So we are blessed to have ma'am with us as the president of this wonderful society, which is taking the feature of aesthetic, functional, and regenerative gynecology, a term coined by her itself, and we are blessing every pertinent member and every gynecologist to take up into their own stream the field of aesthetic, functional, and regenerative gynecology, because it is not about cosmesis. It is all about the functionality of the woman. We do not want them to suffer in silence. And this is what the brainchild of Dr. Ragini Agarwal is. And she wants to take it to every nook and corner of our country as well as abroad. Welcome, ma'am, for your deliberation. Ma'am will be speaking on overview of non-surgical management of SUI.
Thank you, Prerna. Please, yeah. I just want to share my screen. So thank you, Karishma, and I'm so happy. I know when I chosen you, you are going to do a wonder. And you have made it so clear that whatever the confusion in the mind of all of us for the diagnosis of the stress urinary incontinence, it is clear. And literally, Karishma, I can't say how much happy I am by choosing you. You have made subject so easy. So from a real urogynecologist to all of us who are gynecologists and trying to be a part of the urogynecologists. So here I'm going to just give an overview of the non-surgical management of SUI. A part of it is dealt with Karishma. The next part will be dealt by in detail by Dr. Shefali Gambhir, who is a pelvic physiotherapist, and rest two part, the main modalities of the non-surgical management of the SUI will be dealt by our next speakers for the Dr. Preeti Jindal and Dr. Manvi. So we all know that this is something so many women suffer in silence, and with the blessing of God, I will start my presentation. So it is very clear from Dr. Karishma talk that condition is negatively impacts physical and the psychological health of the woman and leading to the social isolation and the sexual dysfunction, as it is a half of all women experience urinary incontinence. And type of urinary incontinence, we all know SUI, urgence, mixed, and clinical diagnosis is sufficient. Very clearly it is given to us by the Karishma. So women most commonly develop SUI from the changes that happen in the pregnancy or childbirth, which weaken the support to the urethra. This is the most common thing, although other risk factor is also going to play a role. But why I am focusing and telling this line, because here our work starts. When a patient of the antenatal period comes for the antenatal time, we have to stress upon the physiotherapy, and we have to stress upon the post-delivery rehabilitation of that patient. If only those two things we are able to do, the patient will maybe not develop the SUI. Even the modalities which is going to be discussed, if they will apply to them in time, their SUI is not going to be going to the degree is going to increase. And at the time of delivery also, we should take the precaution for the very difficult deliveries. These patients can land up, and these things should be explained to the patient that these problems can be arise to them. Now, severity understanding is very necessary, because if a patient of the SUI is a grade 3 or grade 2, your non-surgical modalities are not going to play a big role. You have to understand that it is a milder variety or little bit milder to moderate only at the place where you can give a justice. But if a patient is have a grade 3 variety, severe variety, there you need a operations. So role of the non-surgical is a even a preventive way in a great mild variety where you are not going to offer any operations. So when your patient is SUI has come, you have to think about the non-surgical and the surgical management. When we talk about the non-surgical, there's a long list in RKT, from the physiological approach to behavioral therapy to devices to medication. Yes, few medications are in trial and few trials and few papers are there, but it's still they have not a big role in the cases of the SUI. Then the newer modalities, which we are going to talk in details, are the lasers and the high FEM technology. So non-surgical management is less invasive, low cure rate, require maintenance, and response is the patient's compliance dependent. And specifically, it is very good for the women who are need more childbearing. But when we talk about the surgical, it is invasive, but it really gives a high cure rate. Response is dependent of the patient's compliance, and after completion of the childbearing, only you can offer these things, but they can lead to the complication and which needs the treatment. You have to be very highly skilled. And the way the mesh is going from the treatment in many countries like UK, it is totally banned. You have to focus lots of the non-surgical first, then going to patient offer the birch operation. So approaches are altering the magnitude of the stress that occurs on the bladder and the alteration of the fluid management and the voiding habits. As Karishma has told very clearly, it is the intra-abdominal pressure which causes the most of the problem. And we always say the patient that even after operation, please control your cough. So stop smoking, treatment of the underlying pulmonary condition, treatment of the allergies is very necessary. Chronic cough is one of the reason of the SUI, and weight loss is also play a very big role. Exercise modification, as she already said, the very high intensity exercises can also cause problem, reduce heavy lifting, and avoid chronic straining with the constipation. In a paper, it was found that a reduction in a BMI even leads to a very substantial loss in the substantial improvement in the SUI. So in these patients, we have to ask about to go the low impact exercise, and a high impact exercise should be reduced. We should remember that it is very important to know that the adequate bowel movement plays a very big role in these cases. So appropriate relaxation of their anal sphincter when they are trying to valsalva. A significant number of the women will come in with a chronic history of the constipation. When they strain, actually they are contracting their pelvic floor and they have a non-reflex puborectalis. So this is very important to understand whether the pelvic floor is hypertonic or the hypotonic, and patient need a biofeedback type of the approach for treating the constipation in these patient. Alteration of the fluid management is very important. Keep appropriate fluid intake on 6 to 8 glass and ensuring that patient will void at the regular intervals. Not let their bladder become too over distended. Behavioral changes like bladder retraining is primarily used for the patient with the urge incontinence, and the mainstay of the behavioral therapy is going to be the pelvic muscle rehabilitation or the pelvic floor exercise. Kegel exercise, we all talk about the Kegel exercise, but Kegel exercise is whether it is effective or not, it's a question mark, because no consistent technique, patient do not have a patients perform exercise while widening, patient must strengthen the muscle and recruit the muscle, and it is very difficult to explain them. Adjuvants are vaginal cones, biofeedback, electrical stimulation, and the extracorporeal magnetic innervation. That is a new therapy in the market. Comparison of adjuvants to pelvic muscles exercise, it is found that if the adjuvants are used, then it is a more effective. Effect of adding biofeedback mean to treat the SUI. There's the RCT of the 6 months of the pelvic muscle exercise with or without home feedback, and it was fine. They're almost comparable. So in terms of the supportive or the occlusive device, we have intravaginal devices which are designed primarily to support a hypermobile urethra device, mainly addressing the urethra itself. Intravaginal devices support a hypermobile urethra and the partially compresses the urethra, like tampon. We have tampon-like devices also, continence rings and the pastries. These continence rings and the pastries is coming back in a very, very big way. Even in the UK NHS, they have a incontinence OPD separately, and they have full pastry to explain to the patient, and the patient come back and show whether they are using it properly or not. Occlusive devices block urine from the exiting the urethra. So difficulty with the vaginal devices is that the patient requires some component of the pelvic muscle tone or pelvic floor tone to be able to retain these devices in their proper position. So mechanism of action is like it is found in the urodynamic studies that they improve the urethral function, increase in the functional urethral length, absence of the urethral obstruction to flow, and resolution of the detrusal instability. Anatomically improve urethral support as there is reduction in the straining Q-tip angle, but the Q-tip angle we are not doing nowadays, and the dynamic magnetic resonance imaging studies show a decreased posterior uretrovesical angle. The translabial ultrasound is coming in a big way, where we can have a dynamic movement even by the ultrasound, and the dynamic pelvic MRI. Also, these studies show how much is the cystocele, rectocele, and the pelvic dysfunction, and how much you have corrected after the operation or after the devices. So not only the SUI, it has an effect on the POP also as a first line therapy. And now the many type of the pastries are present there, and they have improved. Even the silicone pastries are there. So when they are compared with the other treatments, the pelvic floor muscle training for SUI, so it is found that the PFMT requires more time, pastry needs less time. PMT no adverse effect, but when you do the pastry and the proper care is not there, it may lead to the vaginal erosion and the malodorous vaginal discharge. The highest quality of data regarding this issue are from the ambulatory treatment for the leakage associated with the stress incontinence trial, and they're the continence pastry or behavioral therapy versus the combined use of the pastry and the behavioral therapy. In the 3 months, the behavioral combined group reported a complete absence of the bothersome incontinence symptom and treatment satisfaction. In women with the POP, pastry use combined with the PFMT improves POP symptom more than the PFMT alone. So clinical scenario in which pastry is indicated, patient preference for the non-surgical treatment, presence of severe medical comorbidities, delay surgery, recurrent POP or SUI, and a patient preference for the avoidance of the repeat surgery, vaginal ulceration caused by the severe POP, POP in a current pregnancy, and a desire for the future childbearing. It is the most important reason for not offering our operation. So pastry treatment of urinary incontinence has found a percentage who continue to the use pastry long term, almost 64% are improved. Then there's a urethral devices have been addressed primary occlusion at the urethral meatus with either a patch type device or have been used in the past or something like the capsule. We don't have this device with us. So there's an incontinence pastry. A few pastry are designed specifically to treat the SUI when fitted properly. An incontinence pastry compresses the urethra against the upper posterior portion of the symphysis pubis, causing an increase in the urethral resistance that prevents leakage associated with a sudden increase in the abdominal pressure. So these are the pastries which are available now in the market for the as an incontinence pastry. There's a knob which presses on the urethra. So there's a bell-shaped incontinence pastry and the cylindrical intravaginal pastry. There's a less commonly used incontinence pastry. So we have to see examine those patients whether they are associated POP also, and or only SUI. If the rig procedure is not successful, then the incontinence dish pastry can be tried. The few drugs are in the trial and they are giving some promising result, like the norepinephrine and the serotonin effects on the own of nucleus, and this is affecting the neurotransmitters norepinephrine and primarily at the neurological nucleuses. Duloxetine is also coming up with many trials and find to be quite effective in this area, but in nutshell, as of today, we are not offering more of the medical treatment, but either non-surgical or the surgical treatment. So non-surgical treatment option for SUI is able and willing to perform PME, willing but unable to perform PME, unable to unwilling to perform exercise. And biofeedback, electrical stimulation, extracorporeal magnetic innervation. If all fail, then patient has to go to surgery or trial be given for a medication. Then we have a fractional carbon dioxide laser for SUI. It is safe, visible, and beneficial treatment for SUI. It will be dealt with Dr. Preeti in detail. And we have many energy-based devices in our kitty, like fractional carbon dioxide laser, erbium YAG laser, diode, and radio frequency and the HIFU. So next thing, what we are offering in these patients are the PRP. Along with the laser, we do the PRP injection in the paraurethral space, and along with the laser, they are giving a better results. Then we have electromagnetic chair, which is doing 10,000 Kegel in a row. Dr. Manvi Verma is going to talk about this in detail. To conclude, women with a bothersome leakage on coughing, sneezing, or physical activities wishing treatment, lifestyle advices in the form of the dietary and the fluid intake, weight loss is very, very important. I again focus on the pelvic floor muscle training, which can cause blunder. Medical treatment is not very much offered, and vaginal devices. If everything fail, along with the newer modalities like lasers and the HIFM, only then one has to opt for the surgery. To conclude, management of the SUI symptoms should be individualized and address patient aims and preference for treatment. Therapy should target the symptoms that most affect function, the quality of life. Thank you so much for your patient hearing.
Thank you, Ragini ma'am, for that elaborate talk. And we are really overwhelmed to see the response of the viewers even. And Dr. Narendra Madhotra, sir, your expert inputs on this.
So
Sir.
this is what is exactly, I'm sorry, I'm in the car, I'm driving, so my video is not coming on. This is exactly what we have to see, and people have to know that there is a great role of non-invasive management of all these problems. And these energy-based devices, HIFM chairs, and all, they're there in the armament. And we just have to start using them and develop some good, robust data that they work, and publish some papers in a multi-centric study, and then come out that this is, yes, women can be helped for all these problems by non-surgical methods, and they need not undergo major surgeries for things like this. So very well put, Dr. Agni, very nicely described everything. Thank you for that.
Thank you, sir. Thank you for your expert input, sir. And very rightly said, sir, the wide range of therapy as well as devices in the armamentarium of non-surgical management of SUI is really diverse. And we need to hop into this entire topic for the entire dissection of this wonderful aspect of aesthetic, functional, and regenerative gynecology, where we can resume things with a non-surgical mode. Thank you, Ragini ma'am, for your wonderful deliberation. We now move on to our third speaker, Dr. Sefali Gambhir. She'll be speaking on the role of physiotherapy for surgical stress urinary incontinence. And can we have Dr. Sefali's CV, please? Mona Lisa. Dr. Shefali is the founder and director of the Healing Path, and she goes for an integrated and holistic rehabilitation zone at Gurugram, Haryana. And she has a more than 9 years of experience in the field of physiotherapy. And her trust areas are women's pelvic floor rehabilitation, pre and postnatal care, stroke rehabilitation, healing kinesiology. And we are very overwhelmed, Dr. Shefali, to have you amongst us. The dais is all yours.
Good evening, everyone. Today, I will change your views from Kegel exercise to pelvic floor muscle training. So Kegel exercise is not a everyone cup of tea. As Karishma ma'am said, intra-abdominal pressure plays a very key role in stress urinary incontinence. So everyone is able to see balloon. There is a balloon, which is our abdominal cavity. And in this abdominal cavity, here is our diaphragm, which is a primary respiratory muscle. Here is the rectus abdominis muscle, and here is our pelvic floor muscle. And on the back side, our back musculature, you can say the multifidus. This all four muscles together play a very important role in maintaining the intra-abdominal pressure. If any one of this will affect it, the stress urinary incontinence is a cause. It will cause the stress SUI. So, like in smoking and in asthmatic patients, they are overusing their diaphragmatic muscle. The overuse of the diaphragmatic muscle create the pressure on the pelvic floor muscle. That create the tightness of the pelvic floor muscle by transferring from the rectus abdominis. So the primary cause here is not pelvic floor, here is diaphragm. So we have to release the diaphragm. अगर हम कीगल करेंगे या हम कुछ भी depending upon the exercise plan which you are prescribing, it will give you a temporary relief. That's why the Kegel exercise in a long-term cases is not effective because we are not treating the cause. Another thing, mostly after pregnancy, we see the stress incontinence. Why it is happen? See the balloon. The weight is increasing. It is more moving forward, which is creating the separation of the rectus abdominis muscle. जहां से हम बोलते हैं diastasis recti. Diastasis recti happen इन दोनों का linkage खत्म. Only the linkage is the back muscles. So again, it create a load on the pelvic floor muscles. So here also we are not treating the pelvic floor. Firstly, correct the diastasis recti, then treat the pelvic floor. And again, Kegel is not the solution of this. Another thing is the posture. Posture. Most of the women, specifically in pregnancy or the corporate people, they are sitting not on their back, they are sitting on the chair like this. So what it causes is it causing the tilting of the pelvis and causing the tightness of the coccygeus muscle and the piriformis muscle. That causes the decreased flexibility of the hip joint. Again, the coccygeus is the part of the pelvic floor muscle. If you are not releasing that, then again, Kegel is not a solution. We have to treat first, increase the mobility of the hip, then we have to strengthen the pelvic floor. The last one is your foot position. Most of the women are wearing the heels. Tick tock, heel. You know, the nerve root of your foot intrinsic muscles and the pelvic floor muscles are same. It is supplied by the same muscle, same nerve root, sorry, S2, S3, S4. That is same myotome here, same myotome in the pelvic floor region. The heel causes the inverted position of the foot. The position of the foot is inverted, that again causing the tightness of the pelvic floor. These all are the hidden causes of stress urinary incontinence. Other than that, the C-section, the normal delivery, and various other causes. And other main thing is just avoid the workout in the first 6 months of postnatal period. If you are doing the more strength training, अपनी abs बनाने में लगे हो, that will worsen your diastasis recti, and that again causing you stress urinary incontinence for the prolonged period. So these are the main causes. So it is a link. And another thing is smokers. Why smokers? In smoking, we are mostly using our TMJ. The TMJ muscles and our pelvic floor muscles have a same embryological origin. If you clench your teeth, automatically your pelvic floor is activating. If you find a patient like they are opening just now, they are talking like, yes ma'am, हाँ जी मुझे ये problem है. So means their TMJ is tight. Their TMJ tightness causing the tightness of the pelvic. So these are the main, we have to be a proper assessment while checking these muscles and find the cause, where the cause is its posture, another muscle, or foot position, or TMJ. And there are so many. So next thing is, in treating the stress urinary incontinence, we have to find out if it is a tight pelvic floor or it is a weak pelvic floor, because the treatment plan is different and Kegel is not a solution. Kegel, if there is a tight pelvic floor, you are prescribing Kegel. Squeeze, squeeze, squeeze. You are again tightening that. आप उसको और tight कर रहे हो, it will worsen the symptoms in prolonged cases. For Kegel is only affected in the emergency situation, like that thing is called knack. What is knack? Knack is when you have to squeeze or when you have to lift the weight, you have to squeeze your pelvic floor and then then squeeze knees or lift your weight. That is knack, so that urinary leakage in the sternus activity will not happen. This is only for emergency procedure. Other than that, we have to find out the cause. It is weak or tight. So the common thing to maintain the intra-abdominal pressure is in both cases, the pelvic floor tightness and pelvic floor weakness is the breathing exercises. So breathing exercises, एक small सा tool लेना है. हम बचपन में इससे खेलते थे. So what we can do is, when you are inhaling, जब हम सांस लेते हैं, it causing the lengthening of the pelvic floor. Pelvic floor is descending, and when you are exhaling, pelvic floor is lifting up. Here, the pelvic floor is active only in the exhalation period, not in the inhalation period. So it is affected in both cases, the pelvic floor tightness also and weakness also. So how we will go through that? Firstly, I am inhaling. I have to meditate on my pelvic floor. So basically, firstly, we have to educate the patient what is pelvic floor. See, pelvic floor is this very small muscle. It is not that कि आपको ये movement दिखेगा. It is very movement. Patient is unable to do that. So to उसको isolate करने के लिए, what we have to do is, हम बोलेंगे just blow the candles. When you are blowing the candle, you are squeezing your pelvic floor. So it's a signal how you can isolate your pelvic floor. So while I'm inhaling, ask the patient, imagine his or her pelvic floor is moving out. When exhaling, his pelvic floor is moving in. So you can use, instead of this, the spirometer. So inhale, exhale slowly and blow it. The voice is give you a feedback how much he or she is able to hold his or her pelvic floor. If exhalation period is prolonged, then his or her pelvic floor is good. Otherwise, इतनी जल्दी ही छूट जाएगा. So I'm inhaling. This is the one common exercise for both pelvic floor tightness and weakness. Other than that, there are various exercises, and we have to correct the diastasis recti. How we correct the diastasis recti is with dry needling. Dry needling is the acupuncture needle in which we place it. There are the various four fibers of the diastasis recti. So this is umbilicus. From umbilicus, we perpendicularly insert the needle towards the diaphragm, then on sideways, and then downwards. With that, we lift the patient legs like this and place it on our shoulders and ask her, press your leg as much as you can. That activate the rectus abdominis. We can use it without needling also. So it is the activation of the rectus abdominis, so that load on the pelvic floor become decreased and the symptoms of stress incontinence will improve. Other than that, the positioning of the foot. Most of the injuries happen because we are wearing a very branded shoes. हमारे foot बिना चप्पल के हम चल ही नहीं सकते हैं. So the sensation of the foot are lost. So in pelvic floor rehab, foot rehab is must. If you are strengthening your intrinsic muscles of the foot, you are strengthening your pelvic floor. How you can strengthen that? These are the balance stones. 2 balance stones. इसके अंदर कांटे लगे हैं. पहले एक एक्यूपंक्चर प्लेट आती थी, but that was the stable square form. This is rounded shape, so we have to stand on that, so that if, like I am standing, I am gripping it, so I required a more effort to grip that. And other thing is that spikes hurts me, so it give you a sensory feedback also. Previously I told you the nerve root of the intrinsic muscle of the foot and pelvic floor muscle is same. So the foot rehab is must in this patient. And another last thing is the relaxation of your jaw muscles. How you can relax that? Patient को बोलो balloon फुलाने का, so that masseter muscle will glow. Other thing is self-release. पेल्विक फ्लोर एक हमारी स्ट्रेस मसल है. जब भी हम डर और फियर में होते हैं ना, सबसे पहले हम अपना दांत क्लेंच करते हैं, ये चीज करते हैं. दैट अगेन गिव यू अ ट्रॉमा टू द पेल्विक फ्लोर. सो पेल्विक फ्लोर इज लाइक अ फियर मसल. आपका कोई भी फियर है, कोई भी ट्रॉमा है, वहां पे फंसा होगा. सो वी हैव टू रिलैक्स, और वी कैन इंसर्ट आवर थंब and release. That automatically release the pelvic floor. And the coccygeus muscle, for the posture people जिनको ऐसे बैठने की आदत है, you have to place a ball. You can take a Costco ball, not a Costco ball, hard ball, leather ball, or a tennis ball, depending upon your bum size. You have to place here, just below the ischial, 2 fingers between the ischial tuberosity at the tailbone. You have to place the ball and just move your buttocks, release that coccygeus. And just above here is the piriformis muscle. That is also a part of pelvic floor. You have to place the ball here, then roll on it. That will release you piriformis muscles. So these are the hidden truth of the pelvic floor rehabilitation. Everyone know the Kegel exercises. So here today I'm it's an eye opener for all of you, I think so. Well, thank you so much for giving me the opportunity. Thank you, Ragini ma'am. Thank you so much, Prerna ma'am.
Thank you, Dr. Shefali. That was indeed an eye-opener for all of us gynecologists, that even masseter muscles can help tightening the pelvic floor muscles and the relation of the foot as well as the entire body muscles to that one pelvic floor muscle. That's really, really great to hear you. Dr. Narendra Malhotra, sir, for your expert input, sir.
Dr. Milind has joined.
Also, Dr. Milind, sir, Deputy Secretary General of INSARG.
Yeah, yes, thank you very much, Prerna. In fact, suddenly I was a bit held up in one cesarean section and I could not join on time. But it was really a wonderful, actually, lecture, Shefali. And then I could see all those newer actually aspects of the physiotherapy as well. This was the third lecture we took first, Prerna?
Yes,
Hello?
sir. That was the third. This is the third one.
Third one, yeah, correct. Yeah. So basically, we all were knowing about Kegel, but even the Kegel master as well. But again, these small gadgets can definitely make a major difference as well. Shefali, just wanted to ask you where these gadgets are available. I mean to say, these all the things which you have shown, they're easily available in the market.
Decathlon. Sir, Decathlon.
Pardon?
Decathlon. Decathlon.
Okay. Oh, acha, great. Very nice. Yeah. So I'm very sure all those OBGYNs who are observing it, that will definitely make a major difference, because I remember I'm practicing since last actually almost 35 years. But recently when my daughters joined, they started bringing balls in the labor room and started using it. So I realized, yes, the days are definitely changing and we need to adopt with this all new changes, because every woman wants to get herself rejuvenated as she was before the pregnancy. So wonderful talk and very nicely demonstrated. I'm very sure everyone will definitely follow all these actually things meticulously to see that all those muscles regain their normal actually functions even after childbirth. Good. Thank you very much. Yeah. Yes.
Thank you, Milinsa, sir, for your expert inputs. Do we have Narendra Malhotra, sir, with us? So sir was traveling somewhere. So with this, we are done with the first session, and we are really, really overwhelmed to see the viewer expert response, as well as our expert chairpersons and speakers of the first session really did a wise job to their entire deliberations, and we are really overwhelmed that you all joined in for the wonderful session and for the wonderful topic of SUI and enlightening all of us out here. So we move on to our next session that will be newer non-surgical management modalities of stress urinary incontinence. And to chair the session, we have Dr. Narendra Malhotra, sir, patron INSARG, and Dr. Tanuja Uchil, ma'am, who is the treasurer of INSARG. And can we have Tanuja, ma'am, CV, please? So Tanuja ma'am is quite a good friend of all of us here, and she is a diploma in reproductive medicine and gynae endoscopy, as well as founder director of OMA Hospital from Mumbai, India, and principal consultant of OMA Hospital. Right now, as the treasurer of INSARG, she has taken this society a long way through, and she is a member of International Society of Gynecological Endoscopists, and many more presentations and papers to her credit. We welcome you, ma'am, for your deliberations. And for the first talk, we have none other than Dr. Preeti Zindal, ma'am. Dr. Preeti Zindal is our very beloved, very dynamic, and very outspoken gynecologist and aesthetic and regenerative functional gynecologist, rather than we can say. She is a Secretary General of INSARG, and under her apt leadership, INSARG has seen many phases, right from the nurturing period of kindergarten to what stage today it is that we are into every nook and corner of the country. Welcome, Dr. Preeti Zindal, for your deliberation, energy-based devices and adjuvant. She is an expert in this field, and her armamentarium has a diverse range of instruments and devices to treat SUI non-surgically. Welcome, ma'am, for your deliberation.
Thank you, Dr. Prerna, and thank you so much for giving this opportunity. And first of all, I would like to thank our president, Dr. Ragini ma'am, who is a big visionary, and she is the one who is the driving force for all these webinars and spreading the knowledge of aesthetic and regenerative gynecology to all the gynecologists. Her vision is that every gynecologist should be practicing the cosmetic and aesthetic gynecology, and we all are following her guidance. Thank you so much, ma'am. Now, my topic is energy-based devices. Now, as this is a master class, I'm not going to do any slide share. I'll be speaking, and if there are any questions, you can put it in the chat. We have heard our initial deliberations today, our initial lecture. So now, what are the energy-based devices? These are the new armamentariums which we all have in our kitty, and as a gynecologist, we all can get trained for using these devices. The energy-based devices are basically the devices which deliver the energy to any particular part and cause and lead to the results. So main things which we use in our kitty are the lasers. Then we have radio frequency devices. We have high intensity focused ultrasound, HIFU techniques, HIFEM technique, that is high intensity focused electromagnetic vibrations. Now, as a core gynecologist, we all are very scared of adapting these new energy-based devices, but they are very, very safe devices provided we know how to use them, we know their mechanism and where to use them. So one by one, I will be dealing with each one. First of all comes the laser. Now, laser is a very old technology which has been used everywhere in the medicine since many, many years. In gynecology, it found its use recently, say in around 10 to 12 years. And in India, it has come more after the 2015 and 16, when more of the gynecologists have started using it. So basic principle of laser is that laser focuses a particular beam of electronically charged particles to particular area, and they raise the temperature of that area to 40 to 42 degrees centigrade, bringing about the changes in the elastin and collagen of that area. Aging causes the degeneration of elastin and collagen. So these energy-based devices, no matter whether it is a laser or it is a HIFU, that is the ultrasound or electromagnetic vibration, what they do, they basically increase the temperature of that area to 42 to 44 degrees centigrade. As a result, new elastogenesis, new collagenesis takes place, and the results are achieved. Now, stress urinary incontinence is one area where they have found a very good therapeutic role. Stress urinary incontinence, as you have heard in the previous lectures, is a very common problem in the women, and pregnancy and childbearing actually aggravates it. And also, now as the longevity of life has increased, more women are suffering from stress urinary incontinence. In fact, in one of the studies which we did in Chandigarh, where I belong, Chandigarh and the Tri-City area, we studied around 1,000 women, and we found that around 70 to 80% of women above the age of 70 to 80%, they suffer from stress urinary incontinence. Usually with the aging, the incontinence along with stress urinary incontinence is a mixed form of incontinence, and it's basically because of vaginal atrophy, decrease in retrusor power, and also thinning of the suburethral area. So using the laser and these radio frequency, HIFU, and these energy-based devices, what happens that the local area, suburethral area, there the elastin and collagen fibers get remodeled and elastogenesis takes place and SUI decreases significantly. In fact, we advocate 3 sittings of laser every 1 month apart, and then we have seen that around 90 to 99% of the women, they get relief from the SUI and other urge incontinence and the mixed incontinence. Now here HIFEM, the chair, which you all must have seen, a chair on which you sit, again going back to Shifali's lecture about the Kegel exercises. Now Kegel basically acts on the voluntary muscles, but what we actually need is the pelvic muscle strengthening of the involuntary muscles to decrease the incontinence. That is not possible through your exercises. Exercises are required, which is very good point, but they are basically to give strength to the voluntary muscle. Now, HIFEM, high intensity focused electromagnetic vibrations, they lead to supramaximal contraction of the levator ani and the pelvic floor muscles, and as a result the pelvic floor tightening takes place. It is actually not possible for anyone to do it voluntarily. So if you sit on these chairs for half an hour and you take 5 to 6 sittings of these, it has been seen it reduces even the prolapse, first to second degree of prolapse. Also cystocele, rectocele, and enterocele has been found to reduce. So this is the purpose of the HIFEM devices. So these are the different energy-based devices. We can also use the ultrasound. We can use the radio frequency. Radio frequency device also is used vaginally. There are probes which are inserted into the vagina, and they lead to the tightening and the rejuvenation of the vagina. These were the energy-based device. Now, the second part of my talk was the adjuvants. So different adjuvants are like platelet-rich plasma. That can be very nicely used for rejuvenation of the vagina and also for the decrease in the SUI. So what we do is we take 10 to 15 cc of the blood, then we centrifuge it, and with a proper technique, platelet-rich plasma is formed, and around 0.5 ml of platelet-rich plasma is injected at 3 o'clock, 6 o'clock, and 9 o'clock suburethral. And as a result, the tissues over there, they get rejuvenated, and the growth factors are put over there, which lead to rejuvenation, and that leads to decrease in stress urinary incontinence and also the urge incontinence. So same PRP can also be used for the vaginal rejuvenation. Another adjuvant which can be used is we can use the Botox, botulinum toxin, and or we can use the fillers. So they also can be used and can be injected. But botulinum toxin, it has the role basically in the cases of detrusor overactivity. So that can be injected inside the bladder wall with the help of a cystoscope, and that leads to the relaxation of detrusor muscle, and detrusor instability can be reduced. Simultaneously, it can also be used in the vaginismus. Other adjuvants which you can use the fillers. Fillers can be used just like platelet-rich plasma at 3, 6, and 9 o'clock position. Then nowadays, a lot of study is being done on the stem cells. But stem cell is something which is under the purview of the research. So we need to take special permission from the government to use stem cells. The stem cells also work on the same principle as the platelet-rich plasma, and we can inject them at 3, 6, and 9 o'clock position, and beautiful results come with the help of it. Then other things which can be used, fat grafting can be used, and the fat globules again can be injected at 3, 6, and 9 o'clock, and the similar results can be obtained. So these are the newer techniques which are very safe, non-invasive, painless techniques. These are known as coffee break procedures, and we have been teaching a lot. Dr. Ragini ma'am and myself, we do lots of training courses for these techniques. You all can come and learn about them, and you all can use it in your practice. And it is, in fact, no need, if you don't want to buy the expensive machines, you can start the PRP preparation. The PRP preparation is very easy. It's given on the net in the Google. You can learn from there and can start injecting in the suburethral areas the PRP, and that can also help in treating these conditions. So these are basically a little overview of the energy-based devices and the adjuvants which we can use for SUI. So thank you, Dr. Prerna, for the opportunity, and thank you, Ragini ma'am. It's a pleasure to be always a part of the webinar. And I would also invite all the people to join the INSARG so that you can be part of these webinars and can showcase your work also. Thank you. Thank you so much.
Thank you, Dr. Priti. That was indeed marvelous, we can say. Everyone uses a PPT share and then speak. So we can very well know how thorough you are in your subject and how well versed you are with everyday day-to-day practice of your vast armamentarium, right from adjuvants to your EBDs. You have like nailed it well. Thank you so much. Dr. Tanuja, for your expert inputs.
Hello. Yeah, Preeti, excellent talk as usual. So as Prerna rightly said, Preeti has been an expert in the use of the devices and the adjuvant therapy, and as we call it, combination therapy too, because we know it really works. It works with our patients. I think what is left now is just the feedback from the patients telling how good they feel after either sitting on the chair or the laser or any of the energy-based devices, basically. And as Preeti rightly said, if you do not have the money to start up with the energy-based devices, start with little things like PRP. It's so easy to use, and it does wonders too.
Thank you.
Thank you, Dr. Thank you, Dr. Tanuja, ma'am. And we really second Dr. Preeti's invitation for all our respected delegates to come for training courses as well as to join our organization to make it more stronger and take the brainwave of Dr. Ragini Agarwal in aesthetic, functional, and regenerative gynecology worldwide. Thank you so much, Dr. Tanuja and Dr. Preeti. We now move on to our next speaker, Dr. Manvi Verma, who will be speaking on HIFEM, high intensity frequency electromagnetic wave. That is a chair that Dr. Preeti has already mentioned about it, and she'll be dealing into the entire physiology and the working principles of HIFEM. Dr. Manvi Verma, can we have Dr. Manvi's CV, please?
I want to say one word about the Manvi. Manvi is a only one in the India. She is a qualified MCH in cosmetic problems. So over to you, Manvi.
Yes.
Thank you so much,
Yes. Dr. Manvi
Ragini
Verma,
ma'am.
as Dr. Ragini has already introduced.
Yeah.
Dr. Manvi, let me introduce you formally. She is, as Dr. Ragini ma'am has introduced, she is the only one MCH in reproductive health and sexual cosmetic surgeon from
I'm
Mumbai
in
and has an
MCH
experience of
in
6 years in
cosmetic
this field.
gynecology, not other things. So thank you so much for the
Yes.
introduction. I think
Yes,
I'll
yes.
just share my screen and start my presentation. At the very
Okay,
outset,
okay.
I just want to thank Dr. Ragini Agrawal from the core of my heart. I'm so very, delighted to see her. And I think last time we had met at a conference, AICOG, that was a very fleeting, encounter. But I'm very happy that ma'am has given me an opportunity to speak on the INSARG platform today. Greetings, ma'am. Good evening. And I'm also very happy to see all the office bearers of INSARG over here. INSARG, I would say, is a beautiful platform, and I have seen it grow. The first conference was hosted at Agra in 2022, and then at Chandigarh, and the third one is now expected at Mumbai. So we hope to see everyone there soon. So kindly allow me to share my screen. So is my screen visible? Okay. So I have been given the topic of HIFEM. I believe that it is a boon of this era to have such wonderful technologies in our armamentarium for the benefit of all women. So HIFEM, as has already been mentioned throughout this webinar, is high intensity focused electromagnetic stimulation vibration technology, howsoever, and functional magnetic stimulation is also working on the same principle. So let's move ahead. So this is just the outline of my presentation, how it will open up. So what is the need for pelvic floor strengthening? Then the role of focused functional magnetic stimulation in pelvic floor strengthening, the other applications and available options in India. And then I'll lastly be talking about my experience and conclusion. So what is the need for pelvic floor strengthening? I would say that a strong pelvic floor can improve quality of life. This is very true because the pelvic floor muscles and the pelvic floor is basically a hammock that supports the bladder, uterus, and rectum. So strong pelvic floor muscles are very important for many reasons. They help the body to maintain and achieve a good bladder and bowel control. In the absence of which conditions like urinary incontinence and fecal incontinence may result. SUI is the core of this webinar today. So pelvic organ prolapse is also a strong pelvic floor can help prevent this condition. And as has been mentioned already in the initial stages, obviously, if the woman is suffering from a severe degree or third degree of UV prolapse, all the conservative options are not going to work. So sexual function, pelvic floor muscles play a role in sexual function for women. Strong pelvic floor muscles can improve sexual arousal and orgasm and pregnancy and childbirth. Pelvic floor muscles are stretched and weakened during this very important life transforming phase of a woman during pregnancy and childbirth, and strengthening these muscles after childbirth can help to improve bladder and bowel control and prevent prolapse also. So conditions that can benefit from pelvic floor strengthening exercises, I would say, because the principle is basically the same. We are talking about strengthening the pelvic floor muscles. We may do it by Kegels, we may do it by the newer modalities, but the basic principle remains the same. So urinary incontinence, all kinds of incontinence, I would say, stress incontinence, urge incontinence, fecal incontinence, pelvic organ prolapse, sexual dysfunction, and even pain during intercourse. So benefits of pelvic floor strengthening is for both the sexes, for female and as well as for males. In females, it aids the recovery of the pelvic floor after pregnancy and delivery and renews the vaginal strength post-childbirth. It may improve the sexual health and pleasure also by myriad of ways, like by relaxing the vaginal muscles, then improving the blood circulation to the vagina and the pelvic floor, which can increase the sexual arousal and making it easier to reach orgasm, and also increasing the vaginal lubrication. For males, I would say the lubrication part is very much more dealt with the energy-based devices. We are focusing right now because SUI is a condition which is impacted by multiple of things. The pelvic floor muscles are also into play. The local milieu is also into play, the urethra, the angle of the urethra and whatnot, what has been beautifully explained in this webinar earlier. So for male, it helps to reduce the urine leakage. It may increases the men sexual pleasure by gaining greater control of ejaculation, improvement in the quality of erections, and enhanced orgasm sensation also. So what is the difference between Kegels exercises and HIFIM therapy? Dr. Preeti Jindal has already mentioned that the muscle contraction is voluntary in cases of Kegels, but it is HIFIM, the potentially stronger in involuntary contractions, because we get a lot of patients who don't know and who are not able to follow the Kegel exercises properly. So learning curve, Kegels, yes, it requires learning and a proper technique to do the Kegels. But in the HIFIM or FMS, no active contraction is needed because the contractions are very much involuntary. Then the treatment time may take longer to see the results. It has a potential for faster results. And the effort required, Kegels requires active effort, but HIFIM is a more passive approach. Now, the Kegels versus HIFIM of FMS, ma'am has already mentioned this, so I would just explain it by a visual cue. So this is what are the contraction intensity which is produced by a Kegel exercises. So the maximum voluntary contraction which is reached during a Kegel exercises, so this is the time in milliseconds. So it stays for just like a fraction of a millisecond, but the contractions which are produced, this is the action potential, and these are the contractions which are produced by HIFIM or FMS. So these are supramaximal contraction, and they are also staying for a longer duration of time as compared to the Kegels. So this is the concept which is of maximal and supramaximal contraction. So maximum voluntary contraction is the greatest amount of tension that can be developed and held physiologically by the muscle. But it is usually for a very split of a second. But the supramaximal contractions are contractions with a tension which is higher than MVC. And HIFIM technology creates supramaximal pelvic floor muscle contractions, and the patient is also able to hold them for multiple of seconds involuntarily. So this is again a pictorial representation of how is the pelvic floor. This hammock is there, and then when we subject her to this FMS or HIFIM, so there is like a potential lift in the pelvic floor. So this is again how is this working in urinary incontinence before treatment and after treatment. So there are weakened pelvic floor muscles are there before the pelvic floor exercises are done, and after the therapy is received, the treatment of 30 minutes can provide the effect of 12,000 Kegel exercises and improves voluntary muscle strength by strengthening the pelvic floor muscles, which is the root cause of urinary incontinence. Now, this is a little bit less discussed, like how is this magnetotherapy acting at the tissue level, which is a microscopic level, how it is acting. So it is leading to the stimulation of both the central and the peripheral nerve pathways in the pelvis. Then it also induces a flow of ions at the tissue level, establishing electrical eddy currents that can lead to membrane depolarization, consequently causing pelvic floor muscles to contract and reduce urinary incontinence. Also, which receptors it is acting on? It improves the bladder hyperreflexia by desensitizing C afferent fibers and reducing the C-FOS gene expression. So this is the paper which is the reference for this. So who is the correct candidate who should go for this therapy, or you should consider? Obviously, For all the incontinence patients, history and physical examination is the must, already elaborated. So I'm not going into those details. It is helpful for individuals with weakened pelvic floor muscles, yes, and those who struggle to isolate and contract the pelvic floor muscles correctly. Many a time when during examination we are doing a modified Oxford score to assess the grade of the weakening of the pelvic floor muscles. So it is, the patients are not able to contract the right muscle. So those also, and they have just a flicker of contraction, just range 0 to +1 on that scale. So they really struggle. So they can be considered for the HIFM therapy. And also those patients in which you need a faster result. Many time patient is doing Kegels from so many years and not having results. So yes, those are also candidates, and Kegels has been ineffective, not producing results. Obviously, it cannot be used in all the patients. Please avoid HIFM or FMS if patient is pregnant, because not recommended during pregnancy. We don't have enough data on this. Then obviously, if the patient is having pacemakers, implanted electronic devices, for that matter, any metallic object, you should ask the patient to remove all metallic objects before she is instructed to sit on the chair. So electromagnetic fields could potentially interfere with the pacemakers or other implanted electronic devices. Also, any history of any metallic implant inside the body is a contraindication. Active infection or inflammation in the pelvic region is also a contraindication, which could be worsened. And medical conditions like underlying health conditions like uncontrolled epilepsy, recent surgery in the pelvic area, or certain types of malignancy. And also, I would like to mention coagulopathy. So all these patients should be avoided for the treatment. So other uses, incontinence I have already mentioned, then fecal incontinence also. Then postpartum rehabilitation. So postpartum rehabilitation, it is a very important time wherein the patient, if she is subjected to pelvic floor strengthening, as Dr. Ragini has already mentioned, that if she receives the pelvic floor strengthening treatment in this particular tender phase of her postpartum period, so she is very much protected or less prone to develop the pelvic floor disorders like stress urinary incontinence or pelvic floor prolapse later on in her life. Then pelvic floor muscle rehabilitation after surgery, incontinence also in males due to radical prostatectomy. Many males develop incontinence and chronic prostatitis, erectile dysfunction, problems due to poor circulation. So these are also candidates. Then types of magnetic stimulation, just a little bit of technicality over here. So extracorporeal magnetic stimulation and functional magnetic stimulation. Extracorporeal for urgency and FMS is for stress and mixed ones. So what is the treatment process? So patient basically undergoes, for all the chairs, there are a little bit here and there variation, but the basic remains the same. So it is approximately a 20, 25 minute, 28-minute session, twice a week scheduled for 3 weeks, and 6 sessions total. That is the average, but it may go to even 8 or even 10. Then stimulation intensity maximum of 2 Tesla is or 2.5 even is gradually increased up to a limit of tolerability. So FMS is used with a magnetic coil which is positioned beneath the sitting bottom of the chair, and each patient is instructed to sit on the seat so that the perineum is positioned at the center of the coil. So that patient would feel the muscle contraction or contraction of the pelvic floor and sphincter muscles during stimulation. So these are myriad of options which are available. The FeMiChair is there, then Emsella, Tesla chair, and there is a Viosculpt, and there is this Hypercedia, and a chair by this Cara. So I'm using personally the FeMiChair. So FeMiChair, the specifications are like 2.5 Tesla. It has voice control, easy to operate. It is a very compact chair, and the power consumption and the weight is also not very huge. It is 75 kg. So what are the outcome parameters? As Dr. Karishma had mentioned, the bladder diary is invaluable in the initial assessment, follow-up, and outcome measurement of the patient. So you have, because it is subjective, how would you measure? So there are different questionnaires. Bladder diary is very, which can be easily followed, and you can compare the diaries at the beginning of the treatment and the end of the treatment. Significant reduction of micturition number and nocturia. Then urodynamic test recorded in significant increase. This is from what parameters in urodynamics we should see. And this has been proved that HIFM therapy leads to an improvement in these parameters in the urodynamics, like cystometric capacity, bladder capacity at the first desire to void, mean urethral closure pressure compared with the baseline values. So what are the advantages? Yes, it looks very attractive to have such an option in the armamentarium of the management of SUI, because magnetic fields pass through clothes. Patient is completely dressed, no need to undress, sits comfortably on the chair. So it reaches otherwise inaccessible tissue. So to the depth of 10 centimeter almost it is penetrating. So FMS utilizes the superinductive properties of magnetic field deep inside the body, and thus stimulates muscles that cannot be reached using electrical stimulation. I would also mention in my next slides that what is the difference between the magnetic and the electrical stimulation. What are the advantages of the magnetic field per se. So FMS treatment increases the strength and the endurance. Additionally, patient learns how to properly perform exercises that strengthen the muscle. So patient gave the feedback that, okay, previously I was not able to follow the Kegels, but after receiving the treatment, she is also, aware that which muscles to contract. This provides effective and long-term relief of uncontrolled urine flow and weakened pelvic floor muscles. So yes, it is non-invasive, painless, without any known side effects. Till now in my practice, I haven't seen any side effects. There was, yes, one patient who hadn't responded, but she was more than 90 years history of hydrocephalus and on diuretic treatment. So maybe that was a confounding factor. So improvement can be seen after only a few sessions. Therapy plan is determined separately for each patient by, so individualization is the key. And this was also been mentioned by Dr. Agini. So magnetic fields versus electric field. Yes, magnetic fields are less painful. They allow deep penetration into the heterogeneous biological tissue and they do not require skin contact. FMS does not stimulate pain nerves on the skin surface and is therefore more pleasant than the classic electrical stimulation. Electric stimulation has some side effects like abdominal cramp, diarrhea, pain, and even bleeding. So then a word about how to use the FMS in the overactive bladder syndrome. So it improves the bothersome LUT symptom, which we call as lower urinary tract symptoms in women also we have who suffer from refractory neuropathic OAB not responding to medications. It decreases the number of daytime and nighttime voids in the short term and leads to improvement in the incontinence score. Mostly the ICSI SQ form is used in daily practice. So comparison of magnetic stimulation to pelvic floor muscles training, with all due respect, and Dr. Shifali has also beautifully elaborated on the pelvic floor muscle training. So yes, pelvic floor, the importance of pelvic floor muscle training cannot be, it cannot be overemphasized, but yes, effect of magnetic stimulation on urodynamic stress incontinence refractory to pelvic floor muscle training. This has been evaluated, and yes, it has been found the number of incontinence episodes, degree of incontinence, and incontinence scores were significantly improved after active treatment compared with the baseline. So no therapy is complete or gains acceptance within the society without proper evidence. So yes, there is evidence. We are in the verge of generating evidence. Yes, and there should be multi-centric studies because less number of patients are there. But these are some international studies. There is a comparative study on the effect of high-intensity focused electromagnetic technology and electrostimulation, the treatment of pelvic floor muscles and urinary incontinence. So yes, it was found that HIFM technology is suitable for the treatment of pelvic floor muscle weakening and showed to be more effective when compared with electrostimulation in the short term. Here, I would also like to mention the parameters which they have taken in the assessment. So they have found the 3D ultrasound and they have noticed the decreased AP diameter, lateral diameter, and the hiatal area. And also the questionnaires. So here the pelvic floor disability index 20 questionnaire was used. So this is another one, which is a randomized control trial of the electromagnetic stimulation of the pelvic floor versus sham. And it was found that there was an objective improvement in the provocative pad testing which was compared with the sham treatment. Very less meta-analysis. This is one I could find. So this is an effective meta-analysis of magnetic stimulation treatment for urinary incontinence. So the conclusion was that it is an effective therapeutic modality for the patients with urinary incontinence. And yes, large, high-quality RCTs are needed for longer follow-up period. This is the need of the era. Another one, which is the refractory neuropathic overactive bladder syndrome. The functional magnetic stimulation was used. And there was significant improvement, like in the daytime and nighttime voids, number of pads used per day, the scoring and the urgency symptom. Then this also, the conclusion was that yes, it is effective. Then started studies have been done with a less sample size of 20 women, and all patients reported improvement in quality of life and incontinence scores. Then even 30 women with SUI delivered a treatment course with HIFIM technology for 6 therapies scheduled twice a week. And they also reported the improvement. Again, a study with 30 patients, and 95% of the treated patients reported improvement in the quality of life and decrease in the use of pads. India, I would say, is the largest market for adult diapers. It's high time that we pay attention and improve the quality of life for our women, because women are like, okay, the things which are not, jab tak mar nahi rahe hain, tab tak doctor ko nahi dikhayenge. So quality of life is a very important aspect, and I urge everyone to just look for these issues. So the recommendations, this is the basic standard guidelines, that number of therapies are 6 are required, frequency scheduled twice a week, results like 6-month follow-up is a must, and right candidate are stress, urge, and mixed urinary incontinence. Then yes, I have some patient testimonials, just there is still time, so I was just
The audio of the visual is not.
okay.
We can see them move, but we can't hear them.
Okay. Maybe the audio is not moving. Anyways. So that is all. Thank you so much.
Thank you. Thank you, Dr. Manvi. Thank you, Dr. Manvi, for delving into the minutest details of HIFIM with enough evidence-based practice, and for this confiscated Indian society, where surgical intervention for the woman of the family whose problem she's not even speaking about, hardly speaks about, HIFIM is indeed a boon. And you have really made the right justice to the entire topic, and very less traversed field of HIFIM, which should, I feel, with your vision and with vision of Dr. Ragini ma'am and Dr. Tanuja and everybody, all experts out here, that every from now on, maybe 2050, we will see this particular chair as a lounge instrument, as a lounge reclining chair in all ports and hospital waiting areas, and that such is the vision of our president INSARG. So over to you, Tanuja ma'am, for your expert inputs.
Yes, Manvi, it was a very elaborate and a superbly explained presentation.
Thank you.
covered everything, including the evidence base, and like I said, the testimonials too. So that was it was really very well put, very well explained, with every spot on the dot.
Thank you.
Very well spoken about HIFIM. And what I would like to say is that it's time for us to get aesthetic and regenerative gynecology into the mainstream. I have noticed that people tend to push it on the side. It's just like in most of the conferences, it's just one workshop or one small slot which is given to regenerative and aesthetic medicine. But this is the future, because this is going to be what I say preventive medicine along with treatment-based medicine that happens. Because with every patient who delivers, like I am doing at my place, she sits on the HIFIM chair when she comes postpartum. She gets her laser, so that her life 10 years and 20 years down the line is much better than probably, I would say, ours is, and the generations prior was. So to reclaim their life, to get it better. The inputs today were amazing. It was a lovely presentation by everybody, one and all. It was so informative and so good, and put everything in perspective.
Thank you, ma'am. Thank you,
Thank you, Tanuja. Thank you, Tanuja ma'am. Very rightly said, we have to dig into the problems of our clients. Like every postpartum client can be a client for HIFM. Every postpartum client can be a client for functional and regenerative gynecology. So we really, really are immensely honored to have Dr. Manvi, Dr. Tanuja amongst us for this wonderful deliberation. Thank you so much for expert inputs and the visionary that Dr. Ragini and Dr. Naren Malhotra sir are. They will really, with their incessant efforts, will take this institute and this organization a long way. And we will definitely see a change in the coming 10 years, 1 decade.
I would just like to say
that mainstream gynecology is going to get merged with AFR gynecology. Over to you, Ragini ma'am, for your remarks.
Thank you so much, Prerna. The most beautiful part is your own way of explaining and conducting the whole program. I think it is amazing. And today webinar has given a very deep insight for a problem which is affecting so many women and they are suffering silently, SUI. And Manvi, you have given a wonderful job. And we will meet again on the 7th May with our next program. Thank you so much, everyone. Good night. Bye-bye.
Thank you.
Over to you, Mona Lisa, for a
With-
official.
Yeah,
With
one
that-
second. Yeah, 1 second, Ragini.
Yeah.
Hello.
Yes, yes.
Yes, sir, we can hear you.
Yeah. Ragini, congratulations. It's really appreciable to see so much efforts you're taking. And I joined late, but after that I was saying everyone was so dedicated. I could hear to Shefali, then Preeti, and I could see Preeti was in car, but still she gave a wonderful talk. And Manvi, yes, of course, it's always pleasure to see you. And Prerna, hats off to you as well because conducting so well. So I wish you all the best for the INSARG. I'm very sure it is going to go a long way. Thank you very much.
Lillian, please invite everyone for your annual conference.
Absolutely. All are definitely. In fact, Manvi had come to Sholapur as well. She had been to one of the
What we are going to
one
have
of the
INSARG
cosmetology
annual
events.
in November.
our INSARG
Yeah.
in Mumbai is on 9th and 10th of November.
10. And now we are not going to change the date.
Yeah. So all are
It's
invited. Please do
November.
join the INSARG conference. Thank you so much. Good night.
Thank you.
Good
Okay.
night.
Bye-bye.
Good night.
Over to you,
Good
Mona
night.
Lisa,
Good night.
for
So with
the
that,
We
we
finished
come.
right on time.
Okay, ma'am.
Pardon?
We finished right on time.
Yeah, absolutely. Thank you, Prerna. Great.
Thank you.
With that, we come to the conclusion, everyone. Thank you so much for letting us host the session today. I hope you all had a seamless and hassle-free experience. With all your last comment, we would like to conclude the session over here and really looking forward to hosting all again. Thank you so much and good night to all of you.